Welcome to today's conversation on expanding kidney transplantation, the need to improve organ utilization. My name is Deanna Fenton, Senior Manager of Program Development and Operations here at the Alliance, and I'd like to thank you all for joining us for today's program. Now, before we begin, I'd like to remind everyone that this is intended to be an engaging conversation, and we certainly want to hear your thoughts. That said, should you have any comments you'd like to share or any specific questions you'd like to pose to our presenter, please feel free to submit them in the chat box at any time. For those of you who may not be familiar with Zoom, please note that the chat is located at the very bottom of your Zoom window. Also, if you happen to be using this as a group learning opportunity, we'd like to ask that you take this moment to complete the following poll to indicate approximately how many people have joined your group. Now, to begin today's program, I'd like to welcome our moderator, Gwen McNatt, who serves as the Chief Administrative Officer of the Organ Transplant Center at the University of Iowa Hospitals and Clinics. Gwen, thank you so much for being with us today. I'll go ahead and turn it over to you to get us started.
Thank you so much, Deanna, and thanks to the Alliance for sponsoring this, what I think is going to be a really interesting program. Our speaker today is Dr. Sumit Mohan. He's a professor of medicine and epidemiology at Columbia University. His clinical and research career is focused on lowering efforts to lower health disparities and improve outcomes for patients with kidney disease, but with a particular emphasis on advanced kidney disease and kidney transplantation. He has NIH-funded research and has contributed directly to several changes in healthcare policy at the federal level. He currently serves as the chair of the UNOS Data Advisory Committee, also the chair of ESRD Treatment Choices Learning Collaborative, and a member of the SRTR Scientific Review Committee. In 2022, he received both the Excellence in Kidney Transplantation Award from the National Kidney Foundation and the 2022 Clinical Scientist Award from the American Society of Transplantation for his research related to kidney transplantation. So without further ado, I'd like to introduce Dr. Mohan.
Thank you, Gwen. And I'd like to thank the Alliance for the opportunity to present on what I think is an important topic that is of interest to all of us in the transplant world. So I hope everyone can see my screen. So we're going to talk about expanding kidney transplantation and the fact that one of the things that we need to do, and perhaps an urgent early step that we need to do in terms of expanding kidney transplantation as an opportunity for treatment for patients with end-stage kidney disease, is the need to improve organ utilization. Let's see. Okay, so just a quick list of my disclosures. None of these are essential. There is NIH funding, and I do get paid to be part of the treatment collaborative. So in terms of framework for today's talk, what I'd like to do is provide a broad perspective in terms of how we're going to be thinking about the data that I present, or how I'd like you to be thinking about it in terms of what we think of as how we design a system and what that system provides in terms of results. So the framework that I'm going to ask you to use is one that we borrow from behavioral economics. And Richard Thaler, who's a Nobel Prize winning economist, won the Nobel Prize for his work in behavioral economics and this idea that you can nudge people into making the choices or making better choices depending on how you design a system, right? And so the work he did was around, defaults particularly in 401ks. But this idea has been taken on further, and it's Dan Ariely's book on Predictably Irrational is a book, if you haven't read it, I would argue is an incredibly important book for us in healthcare, just to understand how we as individuals frequently make irrational choices. And he puts it really well when he refers to choice architecture and this idea that choice is an illusion, and the choices we make are actually a direct product of the way our environment is designed. So as an example, just to take this directly from something that we see in transplantation all the time, is we've all seen this question, right? In the event of my death, I agree to the donation of my organs, either at the DMV or on other donor registration forms. And if you took the average group, you could imagine that some proportion of people would say yes, and another proportion would say no, right? Hopefully very few people would say no, but some would. Now, if you preceded that question with a different question that says, I would want an organ transplant to save my life. So I haven't changed the second question. I haven't changed the wording. I haven't changed the structure. I haven't changed anything. I've changed the environment, its positioning. And so the first question is, do you want an organ transplant? And you can imagine if I ask you that question first, before I ask the question as to whether you want to donate your organs, you can imagine that that people are now in a different frame of mind and are going to answer the second question very differently. Now, this is not a hypothetical experiment. This has been tried, and we've shown that when you do it this way, almost 100% of individuals then go on to agree to organ donation, right? So I'd like you to hold on to that idea that our system designs frequently determine the choices that we make, right? So as quick background, some of this is common knowledge to many people in the room, but just to provide some background, ESRD prevalence in the United States is on the rise. We now have more than 500,000 people on dialysis, more than 230,000 prevalent transplant patients, a number that is continuing to grow and will continue to grow because of the burden of disease, unfortunately. And knowing that dialysis is actually not a great form of treatment, right? So when you look, mortality 5-year survival rate for patients on dialysis, we're hovering about 40%. And to provide context, that's pretty much as bad as most digestive system cancers or brain cancers, right? And we haven't moved the needle in well over 2 decades in a meaningful way, which is a real concern, right? Whereas outcomes in the red bars that you see further up are outcomes post-transplant, which are much better. Another way to think of it, is this way. If you look at the entire Medicare population, and you look at those individuals who are on dialysis, which is the dark blue bar, you can see that mortality rate is several-fold higher than the mortality rate that we see in the average general Medicare population, which is represented in orange, right? Now, if these individuals are given a transplant, you see a rapid reduction in the mortality rate across all of the age categories to the point where the mortality rate starts to approximate that of their age-matched general Medicare peers. That's a dramatic and pretty impressive improvement in long-term survival. And like most treatments in medicine that are incredibly effective, it is in fact the cheapest of all the modalities that we have for treating end-stage kidney disease. So there is really no reason that we shouldn't be investing more in trying to grow our kidney transplant program for our patients with end-stage kidney disease in the US. Sorry. And this idea has not escaped CMS, right? So Medicare has, in that 2728 form, the form that we fill out for all end-stage kidney disease patients, has asked the question: have you informed the patient of their kidney transplant option? Trying to encourage clinicians and the caretakers to provide more information to people starting dialysis about transplant and encourage them to go seek a transplant. However, when you think of it from a design perspective, while that's a great question, the very next question is, if patients not informed, please check all that apply. To me, that's a get out of jail free card, right? The idea that, yes, we'd like you to inform them, but if you don't do so, it's okay, right? A clear opportunity on a fundamental form that gets filled out hundreds of times a day across the United States to get it right is right here. Now, the way kidneys are allocated in the US, at least starting back in 2014, was in an effort to try to improve healthcare disparities, allocation time moved from when people were waitlisted to when people were started on dialysis. Whichever was earlier was used as the key point at which people's waitlist time was started. And there were other changes introduced, including the Kidney Donor Profile Index, which is an approximate surrogate for organ quality that we'll come back to. And that was primarily introduced to help centers and surgeons and nephrologists try to evaluate organ quality in a fairly quick, time-pressured situation. But that has introduced its own challenges, and then we're going to talk about some of those challenges and how we can overcome them. So when you change the start of somebody's transplant wait time from when they get added to the wait list to when they start on dialysis, because that's the fair thing to do, and it overcomes the disparity that comes from late referrals. What that also has done is it has removed the sense of urgency to refer people to transplant. right? Because a lot of people outside the transplant community think, well, if you're going to get a deceased donor transplant, you're going to wait 2, 3, 4 years on the wait list. What's the sense of urgency in getting people waitlisted, right? But they overlook the opportunities to get zero mismatch kidneys, or the opportunity to educate people about living donor transplantations, or the opportunities to participate in swaps. And what that has resulted, however, in is a dramatic decrease in the proportion of prevalent ESRD patients who are waitlisted. In other words, the fraction of patients who have end-stage kidney disease who are actively waitlisted is actually shrinking. So our national waitlist relative to the number of people who would benefit from a kidney transplant is actually on the decrease. And it's now at the lowest level it's been for over 2 decades. Now, I'd be the first to say, if we're going to increase transplantation rates in the United States, we need more kidneys, right? We need more donors, living and deceased, to be able to provide more kidney transplantation opportunities. But perhaps a better first step would be improving deceased donor organ utilization. And by that, what do I mean, right? And why would one not want to use a kidney that we would value? Now, clearly, there are going to be instances where kidneys either get injured either during organ procurement or during transportation. Inadvertently, these are delicate organs that require very careful storage and monitoring and transportation. The organ procurement process is reasonably complex, and so an injury can happen then. Organs may be damaged, may have tumors. So there are certainly reasons where you may procure an organ that is not usable, but that's relatively infrequent, right? We would imagine that's a relatively uncommon occurrence, and we're talking about a small number of kidneys. But in fact, we're not. In 2021, 1 in 4 kidneys procured in the United States with the intent for transplant ended up being discarded. Okay, meaning that 1 in 4 kidneys was not used for transplant. It was not used for the intent that was procured, which is transplantation and save a life. That is essentially well over 6,000 kidneys in that year. Given that we only did a little under 20,000 transplants, that's a lot of missed opportunities. Now, why might that be? I'll come back to this. There are many factors associated with poor utilization, but the most commonly cited reasons are what? That there was a poor organ quality, that there was either acute kidney injury, diabetes, or other comorbidities, right? Or there was concerning biopsy findings at the time of organ recovery, these so-called procurement biopsies. Now, we don't have time today, but we've looked at all of these reasons, have identified the fact that kidneys from diabetic donors do almost as well as those from non-diabetic donors, and that acute kidney injury is not a good reason to turn down a kidney. Or that hepatitis C and other comorbidities don't adversely impact how well these kidneys do, and therefore shouldn't be a reason that these kidneys are turned away. Biopsy findings have their own challenges, in terms of both reproducibility and accuracy at the time of procurement, given the circumstances in which they're being performed and being read. There's the increased risk of infectious disease transmission. But my favorites are, it took too long to find a recipient, suggesting perhaps that our waitlist wasn't ready to accept this kidney that got procured, or my all-time favorite, which is no recipient located, with this idea that suddenly everybody's gone on vacation and we can't find someone who'd want to take a kidney like this, right? So if that's not true, the question then begs the question, are there systemic reasons that impede organ utilization? And in order to answer that question, we've got to do a little bit of background work. So like I said earlier, we in the 2014, edits and evolution of the kidney allocation system, we brought in the kidney donor profile index, which is essentially a composite score of organ quality. Takes some features of the donor's demographics, their anthropometric measurements such as height and weight, their comorbidities such as diabetes, hypertension, hepatitis C status, the cause of death, and of course, since we're measuring kidney function, serum creatinine, right? Because it's a measure of kidney function, and this gets converted into a relative risk of failure or performance, which is called the KDRI, or the Kidney Donor Risk Index, which is the raw score. And then it's converted into a percentile from 0 to 100, or 1 to 100, sorry, 1 being the best quality kidney, being the highest percentile, 99 being the lowest quality kidneys, compared to the prior year, right? So it's like getting a SAT score and then having that SAT score converted into a percentile. Now, the first KDPI kidney, right, the first percentile kidneys clearly do very, very well, right? So this, when you read this figure, is we're looking at 1, 2, 3, and 5-year outcomes. The taller the bar, the better the outcomes. It's a proportion of kidneys that are still working at that point in time. So if you look at the 1-year outcomes for the first percentile kidneys, 97% of those kidneys are still working at the end of the first year. If you look at 5-year outcomes, 83% of those kidneys are still working. If you take the 99th percentile, it's 61% of those kidneys are still working. And 61% may not seem like a great number. It seems like it's just over half, or about 2/3 of these kidneys are working. But remember, KDPI 99 are the scraping of the barrel, right? The lowest of the low quality kidneys that we have that are being procured in the United States. But it represents a 20% advantage in absolute terms over patient survival. So only 42% of patients who remain on dialysis are still alive at 5 years. So while it might not reflect a good outcome, it is a dramatically better outcome than not getting any kidney. Now, if you look at it a different way, a lot of times when you talk about discards and the failure to use these kidneys, what I'm frequently told is, well, most of the kidneys being discarded are the kidneys that are being discarded, in the KDPI 85 and above range. These are kidneys that, are at the lowest end of the quality spectrum. Well, I'm going to flip that on its head and tell you, well, if half of the kidneys being discarded are 85 and above, that means the other half are 85 and below, right? Suggesting these are potentially good quality kidneys that we should not be overlooking and discarding. These are kidneys that could potentially be very beneficial for our patients. Now, the problem with the percentile score is you're always going to have some kidneys that are 99, and you're always going to have some kidneys that are 1, but you're ranking kidneys. So sometimes it's easier to look at the raw score and see how these kidneys do. So if I take the KDRI, which is the raw score, and I make a histogram of these kidneys, this is what I get. The lower the KDRI, the better. The higher the KDRI, the worse. I get a skewed histogram that's leaning towards the left, because as you would expect, more and more kidneys, or better quality kidneys, are being transplanted, and fewer quality kidneys are being transplanted. Now, if I did the exact same thing with kidneys that were discarded, I should get a mirror image of this, right? A histogram that is skewed towards the right, very little overlap. Most of the kidneys being discarded are high KDRI scores, very few with low KDRI scores being discarded. But instead, what we get is this. What looks, to my eye at least, essentially normal distribution, right? These bars are all over the KDRI, relatively normal distribution, not the rightward skew that we were originally expecting. And when you put them on top of each other, this is even more worrisome. You actually can't use KDRI to distinguish between a kidney that's going to be discarded or one that's going to be transplanted because of the extent of the overlap, suggesting there are lots of kidneys that are being discarded with perfectly acceptable KDRI scores that we ought to be using. Now, when you talk to clinicians about this, they say, well, we know the KDRI is not a great score. Its C statistic is 0.6 only. It's a little better than a coin toss, and there's so many clinical characteristics about an organ donor that this score doesn't capture, and that's absolutely true. So we went back and we looked at all the characteristics that we know to be associated with high discard rates: older age, obesity, VDs, diagnoses, high serum creatinines, things like that, a long-standing history of smoking or IV drug abuse, and said, okay, how many of these characteristics actually exist in the donors that we are, where we're using the kidneys versus the ones who were not? And we found that at least in 15% of those donors, they had none of these characteristics, not a single one. And as you go across, yes, there are more and more, but it's not skewed again to a right as you would expect, right? Suggesting that there is more to this, and perhaps that it is not quality that's driving the discard rate that we see in the United States, and perhaps there's something else here. Now, if we want to understand whether we're having systemic problems in terms of the organ discard, we have to separate out organ quality completely. So how do you do that? So I had a medical student in my lab who was interested in looking at whether cause of death was associated with discard rates and organ utilization rates and transplantation rates. So we stratified organs by days on which donors, these organs were procured. And what you're seeing here is the discard rate. So the odds of discard go up from as you go through the days of the week to the point where organs procured on a Friday or Saturday are much more likely to be discarded. Okay. So much so that even after you adjust for the organ quality, there's still a 20% increase in organ discards for organs procured on Fridays and Saturdays, which would then be transplanted on Saturday and Sunday across the country over 15 years, right? Clearly suggesting that there is a systemic problem. Now, I will admit that when we published this, we got a lot of pushback. There was a lot of criticism around whether this is an actual true finding. I will say this has now been replicated in the liver world, it has been replicated in the heart world, and we've gone on to look at whether this phenomenon is true by looking at the kidneys that did get accepted. And even among kidneys that did get accepted for transplant and got transplanted, as you can see, organs procured on a Friday or Saturday, we had an almost 10 to 15% increase in the number of people that needed to be offered a kidney before it was accepted. That it was harder to get someone to accept even good quality kidneys, right? Now, when you risk adjust, the effect still stays there, but what I have not done here is I've not removed organ quality from the equation, right? I'm still showing you a pattern, and I'm suggesting that there is clearly a systemic problem here. And the adjustment or the correction that I'm using is quality. So it still hasn't come out of the equation. So the question becomes, how do you remove organ quality or donor quality from that equation? Well, every donor has 2 kidneys, right? So in theory, if we thought that there was a clinical problem or a diagnosis that would suggest, or circumstance that would suggest that a donor was not the ideal donor, and therefore we probably shouldn't be using organs from that donor, one would imagine that both kidneys should either get tossed, or if it's a good quality donor, both kidneys should get used. So this is a result of some work that we did with another one of my trainees who basically said, well, how often does this happen that we have 2 kidneys from the same donor, one ends up being transplanted successfully and the other does not? And we indulged at the time, as a relatively junior trainee, and as a mentor, one of the things that you're supposed to be doing is encouraging people to think outside the box. And you say, well, sure, let's try it, even though I don't expect this to actually lead to anything. And instead, what we found was this: every year, this happens between 700 and 800 times. In our data set, this happened 15,000 times, meaning that one kidney was used and the other was not. And yes, as you go across the KDPI scale, you go to higher and higher KDPI, this becomes more common. But that shouldn't be the case, right? Worse still, if you look at the reasons that the kidney was discarded, one of the things that you see increasing is these orange bars, which is biopsy findings, which is even more perplexing given that biopsies of both kidneys ought to be identical, because we know when you have kidney disease or something wrong with kidneys, they affect both kidneys equally. We also see anatomical abnormalities being reported as a reason as you go across. It's not that higher KDPI kidneys have a higher incidence of anatomical abnormalities, but we think it is probably that transplant centers don't feel like when there is a correctable anatomical abnormality, it's worth the time and effort to fix it, because its KDPI scores already too high. Now, one could also argue, well, who got it right? One transplant center chose to use the kidney and the other transplant center chose not to. Maybe neither kidney should have been used, right? I'm arguing that both should have been. Maybe the center that chose not to use the kidney is the center that got it right. Well, we went back and we looked and we said, okay, what happens to the solitary kidney that got used? How did it do? And when you compare to kidneys from donors where both kidneys got used and you stratify by KDPI, so you're comparing apples to apples, the outcomes at 5 years are essentially identical, suggesting that the center that chose to use that one kidney when it was available of the 2 got it right. So clearly there's a problem here where there is clearly an opportunity for kidneys with good organ quality to be used that we are overlooking. So the question then becomes why? Well, the hypothesis we have is this, that there is unbalanced system monitoring, right? So what does that mean? So I'm going to invoke a different Nobel Prize winning behavioral economist, Daniel Kahneman, who basically coined this idea of the optimism fallacy, right? So for all of you on a call, it's like when you get invited to give a talk 6, 8 months from now, and you say yes because you're like, I will find the time to do it, I'll figure it out. And then 4 days before you're due to give that talk, you're scrambling because you're like, wait a minute, why did I say yes? Because I don't have the time to do this, right? It's this idea that you're going to have more time in the future. That's the optimism fallacy. It's the idea that there are two birds in the bush, and those are the ones I should go after rather than the one in hand. So the way our system is currently designed is we have potential penalties for organ acceptance that leads to poor outcomes. So if I'm a transplant center or a transplant surgeon that accepts an organ, transplants in a patient, and we don't have a good outcome, I have negative feedback, and I have a regulatory system that is not going to be happy with that. But I have no consequence for declining an organ or say no. And it's not that I want to say no for that patient. Part of me truly believes that there is a better organ in the future available for this very patient that I should accept, right? The two birds in the bush. Now, we also know transplantation is a multi-step process with a lot of attrition between starting from dialysis, getting to the wait list. But like I said, the entire focus has been on quality measures post-transplant. There is no attention being paid to offer acceptance variations, to disparities in living donation, or what the attrition rate is as people try to make it onto the wait list. Why is it that we have 500,000 people on dialysis and less than 100,000 of these individuals have made it onto the wait list? What's happening to the other 400,000 people on dialysis, right? Well, and how does that play into our current discard problem? So we went back and we said, okay, let's look at this exercise of organ offers. What OPO calls a transplant center and offers an organ and says, here's an organ that matches your patient on the match run. Would you like it, yes or no? And the way the system works is you get to say yes or no. If you say no, they hang up and they call the transplant center that has patient number 2, and then 3, and then 4, and 5, and 6, and so on, till they find a transplant center that is willing to accept that patient, this organ for their patient in that sequence, right? The match run sequence. So over an 8-year period, it took 14 million offers to place a little less than 100,000 kidneys. So it takes hundreds of offers before someone puts a hand up and says yes. As a result, 84 kidneys, 5 out of 6 kidneys are essentially declined at least once before we find an accept. So it may not go to number 1, it may go to number 2, but every kidney is declined at least once, almost. So that means only 15% of kidneys are actually going to the person they were originally intended to at the top of the match run. And when you turn down kidneys so often, what essentially happens is by the time we finish running our analyses, 3/4 of every patient on the wait list had received at least one offer for a deceased donor kidney, an offer that they were probably unaware of. Fewer than 3% of offers are declined for a recipient-related reason, almost. And so that means that 97% of the offers that are declined are supposedly or purportedly for reasons related to donor quality, right? And when we went back and we said, okay, let's look at all of the deciles, right? So 0 to 10, remember, is the best quality kidneys. They're these from our youngest unfortunate organ donors. You are not going to get a better quality organ. And yet 87% of the times when someone said no to those organs, it was because the organ quality was not good enough. It's like, okay, but these are the best organs out there. You're not going to get a better organ quality, right? Same thing for the 11 to 20. These are the kidneys that we reserve for our pediatric patients because we think they're so good and they're likely to last as long as they do. And so what's happening is that we're running down the match run to get to, patients who. So the median number of days that you have to be on the wait list before you get an organ offer in the US is not 3 years and 4 years and 5 years. It's 14 days. But because people keep saying no to these organ offers, people don't hear about these organ offers for years. And the proportion of kidneys accepted without a single decline, that is accepted for the person at the top of the wait list, is actually decreasing. So by 2015, it was just 12%, 1 in 8. So 7 out of 8 kidneys are being declined at least 1 or more times and going to somebody else with a lower priority on the match run, unbeknownst to the patients on the wait list. Now, that would all be fine if I, as a transplant center, turned down an organ for a patient and said, we're turning this down because we know this is a person or a patient who's going to get another kidney offer for a better quality kidney in a week or 2, right? Better organ, short period of time, sure, I should do that. So we said, okay, let's look at these hundreds of these thousands of people on the wait list who got an organ offer and what happened to them. Did they go on and get the next offer? And if they got the next offer, no harm, no foul, great. The transplant center made a great choice. They made a good decision. They turned it down. Instead, what we found was that nearly 10% of people on the wait list who had a deceased donor organ decline for them went on to die without a transplant. Worse still, they got on average 16 offers that were declined for them. So it's not 1, not 2, we're talking about 16. And they got these not over a 3, 4, 5 week period. And these are individuals who were unfortunately in the hospital with a broken hip and not in a position to accept a transplant. These offers happened over a year or 2, suggesting this is a long period in time. Another 20% ended up being removed from the wait list because they were now too sick to be transplanted. So a full third of patients who had the opportunity to get a transplant never had that happen. 10%, of course, went on to get a living donor transplant, and about a third did get a kidney from a different donor, and another third is still waiting on the wait list without a transplant. And so that has done is it has created this wide variation in the probability of transplantation. So what we all think is, if you want to get a transplant, get on the national wait list, right? That's the thing to do, get on the wait list. And once you get on the wait list, you should get a transplant following a completely objective allocation sequence that treats everybody fairly and equally, right? But if the center has the ability to turn down organs, what we end up with is this system where some transplant centers are accepting a lot of organs, and so the probability of getting a transplant when you are waitlisted with them is very high. And some centers that turn down a lot of organs, so when you waitlisted with them, your probability is very low. So when you looked at 3-year probabilities for patients who were waitlisted in 2015 in the new allocation system, the probability went from 4% to 64%. That's a 16-fold variation in the probability of transplant. That sort of variation does not exist in any other part of medicine, either in terms of access to care or outcomes. That should be an unacceptable variation. And if you look at it, each color here represents a different OPTN region. And as you can see, there is no OPTN region that owns any one part of this. It's completely mixed and completely heterogeneous, meaning it's not where you live that is driving this. It's what your transplant center is choosing to do. So while we look at a large amount of geographic variation in access to transplantation, probability of transplantation, that's probably not a function of where you live. It's a function of what your transplant center chooses to do. How do we know that? Because we've looked at it. So if you look at the old system where you had organ donation service areas, so the way this works is, the country is divided up into 57 OPOs, and organs that were procured by that OPO within their geographic region were first offered to transplant centers within the geographic boundaries of that DSA. And if nobody wanted it, they offered it outside regionally, and then if that didn't happen, nationally, with a few exceptions. But essentially what that means is that all of the transplant centers within DSA have essentially the same organ supply. And if they have the same organ supply and they behave in an identical manner, then the probability of transplantation within that DSA should be identical no matter where you choose to get listed, right? The way to read this figure is every horizontal line represents a single OPO and a single DSA. The diamonds represent individual transplant centers within that OPO. Now let's go to region 9, which is the one in orange. The top line is New York City. 9 transplant centers within a 10-mile radius of each other. the probability of transplantation within 3 years of being waitlisted varies from 5% to 35%, a 7-fold variation in probability of transplantation within a 10-mile radius in a manner that patients do not have access to. This is information patients are not seeing, despite having the same organ supply for all of these transplant centers, implying that this is not a function of the underlying organ supply. This is a function of transplant center choice. And do we know that to be true? Yes, if you look at their organ offer acceptance ratio, which is a function of what proportion of organs that they're being offered they're accepting, higher your organ offer acceptance ratio as a transplant center, the higher the adjusted probability of transplant, right? Not surprising. This should not be that difficult to understand. And so what we want is we want transplant centers that are willing to accept more organs, that are willing to have a higher organ offer acceptance rate, so that they can raise the probability of transplantation for their patients. Now, the challenge here is that this is all not all objective, right? So if you say, well, transplant centers are making the best informed choices about organ quality that you should accept, remember that if we're talking about organs that are turned down by one center, but then taken up by the next center for a patient, right? Which makes you wonder whether those choices and decisions are actually well-informed. Well-intentioned, yes. Well-informed, it's unclear. So this is an analysis by Ann Hummel's group at Cleveland Clinic, where they basically showed that there are donor factors and recipient factors that appear to be driving these decisions that don't seem to relate to organ quality, right? Donor age, donor race, recipient factors such as gender, race, and their underlying comorbidities, including their weight, seems to influence whether an organ gets accepted or not, which is problematic, right? And I think they said it best when they said our findings on differences in organ acceptance may be due to clinical appropriateness. We can't discount that. That may be true. Biological factors, perhaps, or perhaps more concerningly, subconscious biases. Now, what does that mean? Now, I'm going to give you an example again of a subconscious bias. Using that framework, remember, it is a system design that leads to the results that we have. So if you say, well, the difference between the organ quality from a donor that is 69 and a donor that's 70 is minuscule. It's imperceptible when you look at outcomes. It shouldn't make a difference. Yet when you look at the discard rate, organs that come from donors age 69 versus 70, you see this massive jump up, one that is irrational and unexplained, because of what we call the left digit bias, because the leftmost digit now has switched from 69 to 70, right? This idea of going from $9.99 to $10 has this large psychological impact on whether you are willing or not willing to do things. Even when you look at serum creatinine, you go from 1.9 to 2, minuscule, imperceptible difference in organ quality, and this dramatic increase in discard rate. So we have to recognize that there are often subconscious biases that influence the choices we make. And what that does is this, right? Well, so if you talk to clinicians, say, well, it's informed clinical judgment, the KDPI is not all of it. We're making good clinical choices. Well, if you look at what sequence number an organ gets transplanted, that will tell you how often somebody has said no to that kidney, right? And if the more people say no to that kidney, you would expect those kidneys to do worse, because somehow in the clinical gestalt or clinical impression of more and more transplant centers, people are saying this is not a good kidney and I don't want to use it. So if you look at kidneys that say get transplanted in sequence number 1 to 7, right at the top of the match run, say, okay, these are the best quality kidneys because somebody was willing to take them right away or almost right away. Then you say, okay, are those any different than the kidneys that get transplanted in the first 100 patients on that list? And when you look at the adjusted hazard ratio between the best kidney, between what got accepted by the first 7 people on the list versus the first 100 people on the list, there's no difference. What about the kidneys that got accepted by somebody between 100 and 1,000, right? Remember, if you want to get a sequence number 1,000 on the match run got a kidney, 999 people said no to that kidney, or at least those many patients were deemed to not benefit from that organ by their transplant centers? No difference. Even for those above 1,000, there's no difference. So where you get what the sequence number is that an organ gets transplanted at has no bearing on the outcome, calling into question the clinical decision making around turning these kidneys down. Now, what about our newest allocation system, right? Our newest iteration of allocation system, in an effort to correct the geographic disparities in the probability of transplantation and try to reduce waiting times, which, by the way, had nothing to do with geography and had nothing to do with the underlying organ supply, but everything to do with transplant center choice and behavior. Here's what we did. We said, rather than going by geographic boundaries, we're going to go by 250 nautical mile circles. Those are very big circles. So that circle is almost the distance between New York City and Cleveland Clinic, right? Or the city of Cleveland. Very large, very dense area with lots of transplant centers and lots of OPOs, right? Remember, we're not talking about miles, we're talking nautical miles. And so what ends up happening is that now, as a transplant center, I am now connected to many more OPOs, and all of those OPOs are connected suddenly to many more transplant centers, right? So the map on top is the way centers and OPOs were interconnected, and the map below is the new way centers and OPOs are connected, which is completely very, very different. It's a complete mess. Another, schematic, if you will, is if you look at the circle, right? The circle on the left, the blue dots represent OPOs, red dots represent transplant centers. And so each line represents a communication between OPOs and transplant centers, right? That communication, so each center was communicating most of the time with a limited number of transplant centers, and transplant centers most of them were communicating with a single OPO and maybe a couple of other neighboring OPOs. Manageable number of connections, manageable network. You knew who you were talking to, you could figure it out. In the new system, you can see the connections yourself, right? It's all over. People are connected to multiple other OPOs. OPOs are connected to a much larger number of transplant centers. The complexity has dramatically increased. And so the number of organ offers and logistical challenges in getting an organ from point A to point B, or understanding which center is accepting this kidney, has suddenly grown dramatically. And so it should come as no surprise that while the proportion of, the number of procured organs has gone up dramatically, partly in response to some policy changes in the OPO world and more aggressive work by the OPOs despite the pandemic, the proportion of organs being discarded has gone up, and the rate at which the number of transplants growing in the US is much, much slower. If you look at it on the left, if you look at the phase before the pandemic started, during the pandemic, up to the introduction of the new allocation system and subsequently, the rate at which discards are going up in the new allocation system should give us all pause, because that's a concern, and that has to, at least in part, be related to the way our allocation system is designed today. So I'll stop there, and I'm happy to take questions, but in summary, 1 in 4 deceased donor kidneys is being discarded in the US, and hopefully I've convinced you today that it's not related to organ quality, that many of these kidneys are potentially transplantable kidneys, and that even declined organs provide a significant survival advantage to the patients who never got them. And the cost of declining organ offers are borne almost exclusively by patients, resulting in a large variation in organ offer acceptance that leads to there's enormous variability in transplantation that should be unacceptable to all of us. And despite the fact that, for many years, people said the pressure was because we were looking at post-transplant outcome that was making centers conservative, the CMS outcomes measure has now been gone for several years. And yet that has made no perceptible difference on the discard rate. So it's hard for us now to say that that's what was driving our selectivity. We have just gotten more and more selective with an increase in organ supply. All right, I'll stop there and say thank you.
Well, thank you so much for that wonderful talk. I'm going to take the moderator prerogative and just ask you a question on my own. And I think your last couple slides really highlighted that. how much you think the impact of increased cold ischemic time and then the concern about DGF is driving some of this?
So that's a very good question, Ryan. So cold ischemia time on average has gone up about 2 hours in the new allocation system. So that is certainly a concern. I think it is less about DGF concerns and less about cold ischemia time. It is more about just the volume of organ offers that we're getting and what we can do. And so what we're finding in our research efforts is that the transplant system does not appear very elastic. Like the ability to, if we suddenly found 1,000 kidneys under a rock today and wanted to transplant them, we don't have the elasticity or the bandwidth across transplant centers in the US to suddenly expand and right? And so I think that has to be something that we have to think about as a system to say, how do we build a system that is more elastic, that can take on more kidneys and do more transplants, because our patients need them.
So one of the questions from the registration, and please, if people have, I guess I see a question in here from Morgan Reed. Thank you for an insightful and informative presentation. Should the transplant community advocate for amendments to kidney allocation to increase utilization of procured kidneys?
So I would say I'm glad to hear from you, Morgan, but I would say that's a loaded question. I think the allocation system does need revisions. And personally, I think there's a challenge here with the circular system and the logistical complexity that it brings. But I think what we need to do is we need to start by creating a system that just doesn't get people with the longest wait time, but gets kidneys to the people who are going to benefit from it and going to take it, right? So I think our allocation system has to incorporate more nuance in how they match or organs to patients, right? You don't want to give a 25-year-old a kidney from a 70-year-old donor, for a diabetic donor, for example, right? And so we have to get a way to take that kidney and offer it to those people who are going to benefit from it right away and are therefore going to take it. And so thinking about how we do that, how we prioritize that, what the trade-off is between waiting longer on the wait list versus taking the lower quality kidney is a trade-off that is different for every patient, and we have to find a way to kind of operationalize that. One of the things that we all, those of us who take care of patient dialysis centers, that not everybody's the same. You could have a 45-year-old who's doing great on dialysis and has no symptoms and is able to work and do all the things that they want to do. And you can have somebody in the very next year with the same age, same comorbidities, who's struggling with dialysis and hates the needles or is constantly throwing up post-dialysis. Their preferences and choices for the kind of kidney and the sense of urgency that they would want for a transplant are very different. And we have to try to find a way to take patient preference into and incorporate into how we allocate these.
So there's several questions in the registration asking about the major theme is strategies to lower discards. What strategies do you think we can do right now?
So I think the first thing that I would like to see happen is the KDPI to go away. I think the percentile ranking is not the way to offer kidneys, right? So let me put it to you this way. If I got a call, or my transplant center got a call and said, hey, we have a donor who's a 55 or 65-year-old hypertensive who died in a car accident, unfortunately, and the family's donating their organs, that's an organ that I would probably take. Now, if I told you it's a 65-year-old diabetic donor who died in a car crash, and oh, by the way, 98% of all the kidneys that we would get in the United States are probably better than this, that very same kidney is unlikely to be used. And that's where the problem lies. when you do the KDPI is a measure of relative quality relative to all the other kidneys. It is not a measure of quality or value to the patient that you're offering it to. And that's the fundamental flaw in the KDPI percentile. What we should be providing is a measure of what it represents to the patient that you're offering it to. And I think that's how we need to reframe how we do organ offers in this country. If we are going to get people to be more willing to think about whether this organ is the right organ for the patient that it's being offered for. So that would be my first answer. I think there are many other changes that we can use in terms of predictive analytics, in terms of explaining to, show centers what the likelihood is of getting another offer in a reasonably short time frame, and what's the likelihood of getting a better organ offer in a reasonably short time frame. And those are the kinds of things that we need to do if we are going to get people to be more accepting of organs.
So Michelle Reef asks, until the system is adjusted to address this kidney issue, what advice do you have for OPOs so that we can honor these precious gifts?
That's a complex question, and I think that's a challenge in terms of what can OPOs do today. And I would say this: I think the OPOs already have some insights into what works and what doesn't. Right? So, trying to adopt best practices, such as running match runs early in the process, or maybe even before cross-clamp, so you know who you're talking to and what you're talking about. Encouraging transplant centers that you work with closely to have more patients who are ready to go, and trying to help centers overcome these internal holes that clog up the system and create inefficiencies. And then to think about the small nudges in the system things that you can do as OPOs, right? Does it make sense to call somebody to get an organ offer at 2 o'clock when you could wait 4 hours, and you're probably going to get someone that is able to think through it rather than just say no, as an example, right? I would encourage OPOs to look at their organ offer practices to see if there are small adjustments that they can make that lead to better outcomes in terms of centers being more willing to accept organ offers. It's a communication challenge and strategy, but I think it is possible to do even in our current system. To start, to frame these organs in a way that they can be used. I would say that we should be using biopsies to rule in kidneys, not rule out kidneys, as another step. So do I think there are small things that the OPOs can do that can have a large impact? Absolutely. I do think that is possible.
Glenn Matsuki asks, have there been any advances learned from the TACWell Kidney Collaborative?
So that's a good question. So the ETC-LC, or the ESRD Treatment Choices Learning Collaborative, is a large group of teams, includes nearly 200 transplant centers, almost all the OPOs in the country, trying to identify best practices and go through processes. And some of it is driven at the baseline level, and we're still in the process of identifying these best practices and allowing them to float up. As a first step, what we're trying to do is create feedback loops that allow centers to recognize their own practice preferences and their own kind of performance relative to their peers. So that's our first goal. And that's what we're working towards, right? So if you ask any transplant center, almost all of us would call ourselves aggressive, right? And the goal is to try to help people get a more objective assessment of their own performance and how aggressive they are, and whether they're actually using the tools that already exist, things like the RU report or the RAM report, or using some of the new tools that the SRTR has built, to try to help them create a more accurate picture of their own clinical performance and preferences. And we're hoping that alone, as a first step, will start to move the needle.
Peter Brinson asks, What can we do to increase transparency to patients so they are more empowered to make the best choice for their particular situation?
Again, a very good question. So so the thought is, and this has been used both, in various policy forums to both CMS and UNOS. I will, in full transparency, there's also been some pushback from many of my own colleagues. But I think the right way to do this is to make sure patients understand that on occasion that we are turning down kidneys for them. Now, it's hard to do that in real time because of the time pressures, but I can certainly envision a sort of asynchronous shared decision-making model, right? This idea that, so think of it this way: if for those patients who have cancer, we don't make decisions about DNR status and DNI status when they're critically ill. We make those decisions well ahead of time based on that individual's preferences and values, and sometimes they change over time, and as they change, maybe the decisions change. We could do the same thing in transplant, where people say, hey, I would like to know when I'm getting organ offers. So you could imagine once in 3 months, you get a letter or 2 months, you get a letter from the transplant center or from UNOS that says, the kidneys that were turned down for you, and here are the reasons. And what one could do with that is say, wait a minute, I'm doing so poorly on dialysis. I want to have a conversation about whether those kidneys, if maybe we should have said yes to one of those because I want to get off dialysis at all costs. Or I may be an individual that says, I'm doing so well on dialysis, I trust your judgment. Or this is too much information for me and I don't want these letters. But I think those are choices that we should give patients. Let them make informed choices about what it is that they want. Have these ongoing conversations. And those letters can have lots of secondary benefits. If you stop getting the letters or you stop getting organ offers, maybe it's because you've turned inactive, because as a patient, you've inadvertently let your pap smear or your mammogram or your cardiac testing lapse, and it's no longer valid, and you need to go back and get another one. But having that sort of communication between dialysis facilities, transplant centers, and patients is critical. And you can easily imagine how those letters may also stimulate conversations in waiting rooms in dialysis facilities, conversations with the people, the nurses and the patient care techs taking care of these patients. We've got to empower people to have these sort of patient-centered discussions that helps patients make more informed choices, and that helps us as transplant centers make choices and decisions that are more patient-centered. But without the conversation, we're never going to get there.
So another question we had here involves pumping. Do you think that the pumping helps decrease discards or has any effect? Or
so that's an interesting question. I was just at the ASN, and there were some fantastic talks on organ preservation strategies and things that you could do. And I will say the science strongly suggests that there is a lot to learn in terms of organ preservation, and that pulsatile perfusion is probably beneficial. We have some preliminary analysis that seems to suggest that that is actually beneficial. The biggest rate limiting step here has been the fact that we actually don't have good pump data nationally. And so we haven't been able to answer those questions well. And what this points to is, in fact, another shortcoming of our system is that it's not a nimble learning healthcare system, right? Transplant today is very different from what it was 30 years ago. And our data systems have not kept up.
That's right.
The data variables that we capture have not kept up with the science. And so, if we want to use our data in a meaningful way to continue to drive innovation, it has to continue to get updated, and we have to continue to invest in the data that we have as a transplant system. And we haven't done that. So do I think pumping works? I do. Do I know that for a fact? I don't. None of us do, unfortunately.
Well, and then the new allocation system has made pumping more complex also.
Right.
Logistically.
Yes, it has just created it has become just a giant logistical nightmare to get anything done in the system, and it is particularly true in the more densely populated parts of the country. In the Northeast, it has been a real challenge. And I think all of the unintended consequences of circle allocation are things that we need to pay close attention to as we try to rush towards continuous distribution. I will say I am worried. I don't think we're ready for continuous distribution in any way.
I'll tell you, it's logistically complicated in a rural area too, because of the lack of commercial flights.
Oh, absolutely. I think all of it is just the idea that we could, scale up from from one OPO to 12 different OPOs, and that suddenly everybody would have the bandwidth to support that sort of a dramatic increase in logistical complexity, whether you're the receiving end or the sending end, is just I think was unrealistic, and I'm a little disappointed that we didn't plan for this better.
Agree. There's some other comments in the chat that aren't really questions, but Morgan Reed is stating that NKF are strong advocates for communication, as you suggested. And Peter Brinson, who's a transplant coordinator, also wants to highlight how crucial it is to put patients at the center of their care, and is thanking you for your advocacy on this, as we all do, I think.
Thank you, man.
Well, we're a little over the hour, and I don't see any other questions in the chat. So Deanna, do you want to take us out here?
Sure, absolutely. I would just like to say to Dr. Mohan, thank you so much for joining. It's clear just based on some of the comments here in the chat that to everyone's point, your advocacy is very important and crucial on this topic. So we thank you for joining us to share a lot of the insights that you did. It's a phenomenal presentation. And Gwen, I thank you too for helping us to facilitate the conversation during the Q&A. So thank you both so much for your efforts today. And to those of you that are still with us, thanks for hanging on, and we hope you enjoyed today's program and found it valuable as well. For those of you who may be curious or interested in the slides that were shared today, we'll be sure to get those out to all of you so that you'll have access to that, as well as the recording, which will be posted on our website very shortly. So with that being said, I just want to say thank you again and take care, everyone. Bye.
Bye.
Thank you again. Thank you, Gwen and the Alliance, for the invitation.